Good morning. My name is Tracy Trypuc. Welcome to Your Health Matters. Today, we join many in the United States who are recognizing Breast Cancer Awareness Month. Before I introduce my guests, I'd like to share some important information about breast cancer. Cancer is a disease in which cells in the body grow out of control. When cancer starts in the breast, it is called breast cancer. The leading cause of death in the United States is heart disease. The second leading cause of death is cancer. With the exception of skin cancer, breast cancer is the second most common type of cancer in women. About 1 in 8 women, approximately 12%, in the United States will develop invasive breast cancer during their lifetime. Think about that when you're around your friends. If you have 8 friends sitting with you, 1 in 8 of them may develop invasive breast cancer during their lifetime. Each year in the United States, more than 200,000 women get breast cancer, and more than 40,000 women die from the disease. Men also get breast cancer, but it is not as common. Each year in the United States, approximately 2,000 men get breast cancer, and about 400 men die from the disease. Statistically, breast cancer occurs more in older people, around 50 years of age or older. When it is found in younger people, it tends to be more aggressive. African American women have the highest breast cancer death rates of all racial and ethnic groups, and are 40% more likely to die of breast cancer than white women. And now, I would like to welcome my guests, Dr. Roxanne Palermo, a breast radiologist, and Jeanmarie Piotrowski, an oncology nurse from Stony Brook Cancer Center at Stony Brook University. And I would like to thank both of you for joining me to discuss this important topic.
Thanks for having us, Tracy.
Thank you. Dr. Palermo, I'd like to discuss the prevalence of breast cancer and ask if you'd like to add anything to my beginning comments.
Well, you're absolutely right. Excluding skin cancer, breast cancer is the most common cancer in women. It affects over 230,000 women each year, and that's for invasive breast cancers alone. An additional 70,000 women will develop very early stage breast cancer called DCIS, or ductal carcinoma in situ. So you're right on those numbers.
Can we discuss the higher occurrence in older women and yet the more aggressive nature in the younger women?
Okay. So the biggest risk factor for developing breast cancer is gender, being female. The other biggest risk factor is getting older. As we get older, our chances of developing breast cancer increase. Younger women, there is a relatively low incidence of breast cancer in the younger age groups. Of note is that African American women can tend to develop breast cancer at younger ages, under the age of 40. They can also develop more aggressive breast cancers, what we know as triple negative breast cancers that are harder to treat. And they are actually more likely to die from their disease. Those are a few.
Is there any reason as to why? I mean, do they have do they not seek treatment or get know or realize are educated about the importance of breast self-exams or annual mammograms? I mean, is there any specific factor that might be involved in that?
Well, there are a number of factors, and those are mostly socioeconomic factors. I guess the biggest barrier to breast cancer detection for many people, many African Americans, is poverty and the lack of access to health care. They also tend to be less educated about the disease. So those are the main factors involved. So it's very important to educate them about the disease and to, really improve their socioeconomic status and living conditions, and to raise awareness for this disease.
Of note on that point is that African American women are less likely to follow up on imaging findings,
Okay.
and so that impacts the diagnosis and treatment status. They statistically could come in at later stages, and so that directly influences their outcomes.
Is that, do you find that might be a cultural issue because of caring for a family?
I believe that definitely plays a role. There's the Witness Project, which is specifically targeted at African American populations, and it's a community-based group, so they make contact in church groups, community centers, stuff like that, to increase education and awareness to this issue.
All right, great. Thank you, Jeanmarie.
Certainly.
Okay, so now I would like to, that's a good segue, I'd like to move on to education. And I was doing some research about the American College of Radiology and the American Cancer Society's recommendations for the age to start screening mammograms, and the age that they have is the age of 40, and specifically the frequency of getting screening mammograms. And I would like to find out what your if I could get your opinion on that. I know that sometimes recommendations come out and then they sometimes change due to new research. So what is your thoughts on that?
That's a very good question, because there's been, much controversy lately about when to start baseline screening mammography, and part of that was brought on by the United States Preventive Services Task Force, which basically indicated that women who were under the age of 50 didn't necessarily need to be screened on a yearly basis or even biennially. They said that they should discuss with their doctors as to when they might consider starting screening. But as far as the American College of Radiology, the American Cancer Society, they do recommend beginning screening at age 40 if the woman does not have any risk factors. She's not at high risk for developing breast cancer. She's at average risk. Age 40 on a yearly basis is what the recommendation is.
Okay. How, with regard again to education, how important is the role of the, you both can answer this question, or whichever one we want to answer first, but how important is the role of the primary care physician in, teaching their patients about breast exam and the need for a mammogram and looking at their family history?
I think that could be very important, a very important role that they can provide to their patients, because they're the ones who are going to be able to identify, who may be at high risk for developing breast cancer, and then direct them for the proper care. So I think it starts, with the primary care physicians, and then, if they do have a high risk of breast cancer because of a family history, then they should seek a breast, consultation with a breast specialist. They should, at the appropriate ages, be imaged, by mammography and or other tools that we have, imaging tools that we have.
Okay. Then before you answer, then, Jeanmarie, I'd like to ask this question because of perfect timing.
Sure.
At what age then should a young woman be, educated about performing monthly breast self-exams, and have the mother, the whatever, the parent, have this discussion about breast cancer and education about breast self-exams and other methods to screen.
One thing I left out was that, if you do have a family history of breast cancer in a first-degree relative, a mother, a sister, a daughter, then the age at which that woman was diagnosed, or male, 10 years before is when we recommend them beginning their baseline mammography. So that's a difference. So if you are at high risk, 10 years before the age of diagnosis of your first degree relative would be a good time to start screening. I'm sorry, I think I lost your question.
Oh, no, that's okay. But so then, would the pediatrician be,
Yes.
a good source to actually begin this conversation?
So that's a good question. As far as when to have that initial conversation, the incidence of breast cancer in women under 20, under 40 in general, is exceedingly low.
Yes.
But it's good for women to be aware of breast issues at a young age. So in their 20s and 30s, it's good that they every 3 years get a clinical breast exam by a professional, and just have some breast awareness. And we still do encourage self breast exams on a monthly basis, if not for anything else, just to know if there's any change in the breast. And if there are changes, you need to bring that to the attention of your doctor so it could be evaluated.
Well, plus you're also establishing a habit that once you have that habit, then it's difficult to.
I think a lot
bring.
of the key to self-breast exam is becoming comfortable with yourself and knowledgeable about yourself and the way your breast exam feels on a monthly basis. And that's key, because when you're essentially training your fingers and your brain what to do and what you feel like, so that if ever there were a change, your brain would immediately say, wait a minute, that doesn't feel exactly right. So it's a matter of getting comfortable with it and knowing yourself.
And I think getting comfortable with having that conversation, because I think sometimes it seems like an uncomfortable conversation. So oftentimes then young women and, well, even young men, because oftentimes many people don't even realize that men can get breast cancer. They leave the home, they go off to college or whatever else it is, their avocation. And they're not aware, and they don't know that this is something that they should begin to start doing. So that's why I wanted to bring up that point.
Actually, that's important too, to mention men. Usually we see breast cancer in men develop at an older age. Oftentimes they do have benign breast conditions called gynecomastia, where you just have enlargement of the breast tissue. But any man that does feel a lump, especially if it's close to the nipple, that really needs to be evaluated, as soon as possible by a breast surgeon, preferably, and by imaging mammography.
Okay. So, Jeanmarie, I wanted to ask you, what kind of patient education does Stony Brook Breast Cancer Center provide at the Carol M. Baldwin Breast Center? Can you give us
So we have a lot of cancer-specific education and support groups. We have a group for newly diagnosed, and so that's all cancers that are newly diagnosed, so there's direct education and support. There's a breast cancer education and support group that meets monthly. There are other support groups. There's the community education that we do during October, and specifically there's a community update next Tuesday night at the Wang Center for the community at large. We do a lot of outreach, sort of community type speaking, but we do have a lot of organized education and support groups at the breast center as well as at the cancer center. We have a survivorship program, we have a survivorship education and support program.
I think that, and that is very important because when October comes, everybody knows about this is Breast Cancer Awareness Month. But breast cancer doesn't go away in November or December or May or June, and so it's important to be sure that the message continues beyond October. So it's good that you continue to have programs throughout the year and continue to get that message out.
Oh, absolutely. Early detection is still our best friend. Since 2002, there's been a steady decline in the rate of breast cancer, and we've been doing amazingly well as far as treatment and outcomes. A lot of women are diagnosed with breast cancer, but the majority of women go on and do very well. There are 2.8 million survivors in the country, and that's a great statistic.
Yes, that is. Dr. Palermo and then Jeanmarie, you can follow up, but could you please name some breast cancer risk factors?
Okay, well, we mentioned two of them already, and those, most importantly, are just being female and getting older. But then, there's the issue of family history, if you have a first-degree relative who had breast cancer. Early menarche, or age of first menstruation, if it's under 12, that's a risk factor. Late menopause, over 55. Just because of the hormonal influences. Those are the main ones. And then those are really non-modifiable. There's a host of other modifiable risk factors.
And I was reading that with regard to the risk factors, there is no single risk factor or combination of risk factors that has been found that can be used to predict the occurrence.
Well, even if a patient is at high risk because of a positive BRCA status or a breast cancer gene mutation, that doesn't necessarily mean that they will develop the disease. We don't know how to predict that, but they have a great lifetime risk of developing the disease by age 70, perhaps up to maybe 70 or 80% of some of those patients can develop breast cancer.
Okay. Can you address studies that have shown that carrying a pregnancy to full term lowers a woman's risk of developing breast cancer?
So the age at first full-term pregnancy, the younger the age, under 30, the lower the risk. And then, also the number of pregnancies, the more pregnancies, also the lower the risk. However, there is a bit of a transient increase after a first full-term pregnancy in women, and it's usually in older women. So late childbearing is a real risk factor.
But it's not a guarantee, the having a full-term pregnancy.
It's not a guarantee. No. I think the relative risk is a little bit higher.
Right, this is, okay.
And never having had children is a risk factor.
Is a risk factor.
And one other thing I can add, which is important, is women with dense breast tissue. That has now been shown to be an independent risk factor that can place a woman at 4 to 6 times greater risk for developing breast cancer.
And I am going to get to that in just a moment. Okay, so we talked about the screening for their baseline, and so you did say that a breast self-exam once a month, and that should be done 1 week after the onset of menstruation, and then a baseline mammo beginning at 40, and a physical exam yearly. And then as far as mammograms, excuse me, there are different types, and we can't go into all of them, but a yearly mammogram would be recommended beginning at age 40. And there are other studies that can be done. But what I did want to discuss was the breast density law that was signed into law on August 1st on 2012 here in New York, and it's in other states as well. And they're all not the same, all of the laws. But here in New York, insurance companies are not required to pay for some of the treatment, or actually, can you give me a little bit more information about that? I do understand that if a doctor signs like an authorization form, that there might be more coverage. But can you explain about the letter that the women receive in the mail if they have dense breasts? Because oftentimes, if a woman receives this letter, she's not quite sure what exactly this means, and it is a source of confusion.
Sure. The law basically has made it a requirement that the radiologist must inform the patient as to the nature of their breast tissue composition. So, the breasts are composed of fibroglandular, dense or white tissue that shows up as white on a mammogram versus adipose tissue or fatty tissue, which shows up as black. So it's very, it's easier to see abnormalities in a fatty breast than cancers in a glandular breast, because they are the same density. So it can make cancers harder to detect. So it's just to notify the patient that they do have dense breast tissue, and up to 40–50% of the women in the United States have, increased breast tissue density, and then it just facilitates a discussion of, should anything else be done? Can anything else be done to supplement the mammographic imaging? And now many insurance companies have come around, and they will pay for screening breast ultrasound to supplement mammo, for instance, and I'll let you ask the question, because you can go on with.
Do you, as a radiologist, do you wish that the law would include, more coverage? It's a mixed bag, I think. I think it's very good for women to know that there are other modalities out there that can supplement them. I think high-risk women, those who are at a greater than 20% lifetime risk of developing breast cancer, they actually benefit more from MRI, which is a very sensitive test. And we encourage that those women continue or start, a regular schedule of breast MRI staggered with mammography 6 months apart. For those women who, however, don't want to have the MRI or just are not candidates for it, but they are at high risk, then ultrasound is an excellent supplement and should be done in those cases. All right. Unfortunately, I'm not going to have enough time to go into all of the different modalities for screening, but there is the ultrasound and the 3D tomography, and as you said, the MRI. And there's also then the screening. I don't know if you get involved in this, but for the BRCA gene 1 and 2, which are both expensive to have done. What I was just curious is, are there any are there any funds available for women who cannot afford to have these tests?
So it's good to identify women who may be at risk for having a genetic mutation early, so that they can be appropriately sent for testing. The testing is fairly expensive. It's about $3,200 for a complete gene sequencing test for BRCA1 and BRCA2 in the large rearrangements. There are some financial assistance programs from the genetic companies themselves. As well as at the Cancer Center, we have financial aid counselors who can determine, what help you can get and, what would be expected from there. Department of Health and Human Services has programs. American Cancer Society has programs as well that can help with that. There are studies going on, for a sister of a genetically positive patient, for sisters to be tested or siblings to be tested. So there are programs and treatment options. If there's a positive BRCA mutation in the family, anybody in that family can be tested at that single site. So that brings the cost down to about $400 for a single site test.
Okay. So basically, I have just a few questions then left. After proceeding with all of these screening modalities, how do you proceed if an abnormality is found? And of course, that is a question depending upon what exactly it is that you find. But do you usually watch it? Do you usually proceed with a biopsy? Is it a watch and see? Do you have counselors there? I mean, how quickly do the results get back?
So if an abnormality is identified on screening mammography or ultrasound, basically we have to define that abnormality, and whether that looks like it's a probably benign finding has to meet very strict criteria, because theoretically in the probably benign category there's less than a 2% chance of malignancy. So there's very few that should really go into that category. Anything that does not have characteristically benign appearance needs to be biopsied. So we basically channel our patients into the biopsy recommendation, and if necessary, after the results of that are obtained, then we refer them to a breast surgeon if additional workup is needed.
And then if it comes back positive, then you have a team of experts that help to determine what the course of treatment would be.
Absolutely. And there are cases in which it may not come back positive, but it comes back showing abnormal cells or atypia, and those cases some of those cases have a high chance of being upgraded at surgery, so we do recommend surgical biopsy on anyone with atypia.
Okay.
As well.
How important is follow-up after you've had a positive biopsy, say surgery, and say a lumpectomy, whatever the choice of treatment was? How important is follow-up and say mammograms, groups, patient education, and do you find that their patients are compliant with the follow-up?
I find that breast patients are the most compliant, proactive patient group we have identified. Most of them are very good about follow-up, and follow-up in education is extremely important to continue. We should never let our guard down against surveillance. So it's important to keep up your normal mammography if you're recommended to have MRI as a supplement to mammography. Whatever imaging studies are recommended, it's important to maintain a good schedule. Follow up with your physicians for clinical breast exams, continue to do self-breast exams. If you're placed on a hormonal blocking agent, to continue to follow up with your medical oncologist.
Okay. And how many survivors did you say that there were?
2.8 million in the
2.8
country today. That includes women presently undergoing treatment.
That's wonderful. When therapy is not successful, what do you do? What can you do for those living with metastatic breast disease? Are there support groups? Can you assist their quality of life? And what % of men or women, I'm sorry, I asked that one, but what can you do for those patients who have not had successful treatment and are looking for something to help them with their quality of life?
So I'm happy to say that treatment is more successful than ever before in this patient population, and we have the benefit of new therapies where we can change treatments and extend the length and quality of life. So I think it's a more hopeful message than it used to be. And as well, we have support groups at the Cancer Center that can help with that.
Okay. And I was just going to say that we do have a list of the support groups that you have available. They are going to be on the screen, as well as all of your information, your phone numbers, your website, all of the information, I believe your email address as well. So I I want to thank you for, all of this information. And I really appreciate you coming on the show. This is a very important topic, and it is, there are so many people that really want good and accurate information, and so I appreciate you both coming here on the show today.
Thank you for
Thank you,
having us.
Tracy. It's a very
pleasure.
important topic.
Thanks.
Yes.
And that concludes my show for today. Again, I would like to thank my guests, Dr. Roxanne Palermo, a breast radiologist, and Jeanmarie Piotrowski. She's an oncology nurse from Stony Brook Breast Cancer Center at Stony Brook University. I applaud the work that you are doing and your colleagues for both men and women everywhere on this important public health issue. Thank you both for joining me. I would like to to thank you for discussing this important topic. Please join me next week for another Your Health Matters, when we will discuss another important public health topic. Thank you, and I wish you both all a healthy and safe day.
Thank you, Tracy.
Thank you.
Thank you.
Thank you.